I don't know if a lot of people know, but we are the third from the bottom in the number of physical therapists per 100,000 people. Fifth
As a
fastest
state.
is a state, fifth fastest growing area. But all of those statistics get a lot worse once you go rural. So we need to look at graduating physical therapists that will stay here and live here. Pain is a wonderful thing. And this can sound weird, but it's letting you know something's going on. And I always tell a story to my students that there are certain people with no pain, but yet they get burnt, they break things, and they die at an early age. So pain, but chronic pain is not. So I'm just talking here about acute pain.
This is Brewing Better Health, a series from the School of Public Health at the University of Nevada, Reno, where every cup sparks connection and a healthy conversation. Join Dean Muge Akpinar-Elci each month for a cup of Turkish coffee as we pour insights into public health. Today, Dean Muge is joined by Dr. Daryl Lawson, professor and inaugural director of the Doctorate of Physical Therapy program at the School of Public Health.
Hi, Daryl.
Hello.
Welcome to my kitchen and our Brewing Better Health video series.
Thank you for inviting me.
Of course, we talk about a couple things about your research and what you do and everything. But I really want to start with the Turkish coffee side because you were so excited having a Turkish coffee today.
Mm-hmm.
Just tell me about what is your experience with Turkish coffee before?
Yes, I got my academic doctorate at Loma Linda University, and it's very international. And I befriended a person from Jordan who invited me over for dinner. And they asked if I wanted coffee. And I said, well, sure. And they brought out this little thing. And I'm thinking, well, that's kind of a ripoff. You know, I didn't know, because I never had Turkish coffee. I liked it so much, I asked her for another one. And she goes, are you sure? No. I go, this is great. Well, we talked till 2 a.m, my friend and I. And I'm not kidding. We covered all topics of the world, including our academic, political. We just went on and on. And
no, it's
so I've learned
like
you just
small,
drink.
But,
no, you just drink one.
Strong.
It's really good.
But I'm glad that you enjoyed the Turkish coffee. But connecting with the Turkish coffee, because Turkish coffee is again not just a drink for us. This is more relationship and conversation over the Turkish coffee, and for us it's very cultural, traditional things. And I want to start with the one proverb. Actually, a cup of coffee is remembered for 40 years. We always call that way. Because for us, it means really small act or small gesture, just bring you to joy. And just you will be remember that moment, just a long, long time. So do you have that specific kind of moment in your life with that small gesture?
I'm a clinician, a physical therapist, but also work in the community. And what I've learned is that you can plant seeds in people about health. And sometimes you don't see that right away, but many years later, that seed you can see starting to blossom in terms of better health within an individual or a community. Or maybe you may never see it, but it may blossom. So I think that's similar to what I have experienced with being a clinician, but also working in the community.
So just tell me about right now, because you are a clinician, you are a physical therapist. You're in the public health, and you are in the Brewing Better Health public health talk. So why you are here what is the connection with the public health?
There is a huge connection because a lot of times we have patients, and some people might say, well, if you just tried harder, if you just did better for that back pain or that wound or whatever you're treating. But if you really look and listen, it could be more of a public health. Maybe a transportation is the reason they can't get there. Maybe it's their housing. Maybe it's their diet or food. There could be so many other things why this person that walks to your clinic is not getting better. So that's why it attracted me to get optimal health. And we have to look at the whole community of where they live and what they do, instead of your little time with them in the clinic.
Exactly, because just the people that sometimes they confuse about the public health also, just what is the connection with physical therapy or many other clinical piece also. What is the connection? Because we are not a clinical, healthcare provider in many sense, what we see. But what you mentioned, that we see the patient in the community and how we can help them for that their problem, because everything is prevention too. And just tell me about a little bit the prevention side of the physical therapy too, because you guys prevent the problem.
We do. I'll mention a couple, and one might be interesting. We know that people who smoke have within their arteries and system vasoconstriction. It's a hard time for them to heal. So if we can help people get off smoking, when they have an injury, they're going to heal quicker and they're going to heal better. So that's a huge one. Also, another big thing is fall prevention. The fall prevention is gigantic right now. And why do people fall? Well, there could be many reasons. Their eyesight, their musculoskeletal system, their vestibular. There's lots of reasons. But to go out and do screening and help the community to prevent falls, and then have it could be exercise that they do to get better and prevent falls.
Their home place, just they have a specific carpets constantly.
Absolutely. Right. Looking at the home.
They don't have proper stairs,
No, you're right. In doing that kind of evaluation at home. So that not only is a better quality of life for the person, but saves our healthcare lots of dollars. Like I said, better quality of life for the person, and the morbidity, mortality of after someone falls after a certain age is kind of scary. So that kind of community activity is worth it.
Getting that parts. And also, I want to talk about a little bit more the healthcare access side, and just the physical therapy is very specific discipline sometimes, and just the people, if they don't have the good healthcare insurance or anything, and they just they don't get that access. And the healthcare access is getting more important with the situation. So what do you think in the physical therapy world? What kind of technology you started using, and what you do in that part?
Yeah. People initially think that when they go to physical therapy, it's a prison sentence. I got to go 3 times a week for you. That's
they
what I always hear.
Me.
That's what they say. Pain and torture, physical. That's what I always hear. But as we move forward, you're right. The access is limited, or the insurances limit them. So we need to start to be smart and use digital health or telehealth as a hybrid approach. So someone hurts their knee or hurts their back, they'll have initial consult, but then we can follow them up through telehealth. My particular research is using sensors and being able to treat and monitor someone at home with a diabetic foot ulcer. So they could be in a very rural area. They could come, we could examine them, make sure that's okay.
They don't have maybe transportation.
No transportation, or maybe no wound center close to that rural area. And we need to use the 21st century. I always point to my watch, and on the back of the watch is a sensor that does the same thing. I can monitor blood perfusion. So it's nothing that new, but it's us using and leveraging that so we can monitor our folks. And if they're not doing well, we can call them up right away and prevent something a little worse. So if we see they're not compliant, or the blood flow is going down, or whatever we're measuring with our sensors, then we can call them and make sure that everything's going okay before it gets too bad.
That is, that is the important part, and this is the public health side also. How we can provide that healthcare access according to the vulnerable population, or who you are and what you do. That is the piece. So then, Daryl, why you're here in Reno? What's bringing you to Reno?
Well, I know how beautiful it is here. I used to live here a while back before I went to North Carolina and taught at a university there and in Michigan. And then I heard there was a director of physical therapy program position open. And I met a lot of the community here, and they were so welcome. And everybody is so excited about getting a program for so many reasons. So I accepted the position. And that's why, yeah.
That is the nice part. And when you came to do that first time, we talk also, and I explained the mission and vision and everything. But you tell me that also it was very excited moment for you because also we are creating this program under the public health.
Right.
Can you talk about the why?
Right.
This
so
is interesting for
public
you.
health, an umbrella with the physical therapy, plus in addition is an R1 university. So now all of us can work together to do that preventive things we mentioned a little bit earlier. We can work together on all the big research projects our community needs to know to produce what we call evidence-based care and then help prevent some of this stuff. So in a school of medicine or other departments, the focus really is on patients and one-on-one clinical. And if I do research, it's like a randomized clinical trial for those patients. Here, we look broader, which is really exciting. So we can then make an impact on our state with some of the things we do.
That is the nice part. Yeah. And but with also you have a couple really interesting ideas about the program, how to build this program, because this is totally new program.
Right.
In the Northern Nevada, we don't have, this program does not exist, and also huge shortage in the state.
Right.
Just can you talk about a little bit state needs, and also when you are building the curriculum and everything, how you put to that perspective to the curriculum?
Yeah, it's good, a little scary, but it's good because, but we have an opportunity. And I don't know if a lot of people know, but we are the third from the bottom in the number of physical therapists per 100,000 people. Fifth fastest as a state, fifth fastest growing area. But all of those statistics get a lot worse once you go rural. So we need to look at graduating physical therapists that will stay here and live here. The unique thing about the curriculum is designing what I call a good primary care physical therapist. So when you go out to the rural area, you need to see that person who walks through the door that might have a stroke, to a knee problem, to a shoulder problem. That's what the rural folks have been telling me. When we're here in Reno and Sparks and Carson City in this area here, I've been an advocate of not only graduating good, great baseline physical therapists, but then establishing here, which there's none, residencies. So if they want to be a board certified expert in something that's really needed here, they can do that. So a lot of the hospitals and clinics are interested in doing that, but our job is to do great entry level physical therapists.
Great. Mm-hmm. But also with the connecting with this technology and the digital health, because this is your research too, and everything. How you want to implement that perspective in the curriculum too?
There's going to be a course in bringing our students up to the 21st century, as I call it, and looking at telemedicine and telehealth, working with people like engineers who develop sensors and who develop this type of technology. So we're able better to treat, with the few people we have, a bigger population. And I think we can do that through technology. So in our curriculum, we'll be talking specifically about this and bringing in different technology and then having the students think, what could I do too? So
because especially with your mission and your vision, just creating the more primary health care provider perspective, when you add this digital health piece, hopefully that connecting with rural health, also healthcare access piece will also, we will help for future to how to access the healthcare piece.
If we could develop what I call a platform, and I might have a piece of the platform and what I do, but other people might say, wow, you've developed this already. I would like to jump in here. Here's my idea. So they can get in our platform, whatever their particular ideas, and use our technology that we've already developed.
Technology. But what do you see as a future also? What is the importance for preparing to this healthcare workforce for future? Just what we need to really focus.
We need, this sounds like a joke, but we need people to stay here, graduate from our program and stay here. And the call for us as to get people from Northern Nevada, Nevada in particular, and have them go to school here. But more importantly, have them graduate from here knowing what evidence-based practice is from what we learn in the School of Public Health and from the individual to the populations. So we can start that, what I call standard of care, and then go out from there. And I think sometimes public health gets maybe a bad name doing certain things. I think we could change that at the individual level and at the population level if we start to teach that early in the program.
So we talk about the future, what you see, and how we make our students especially stay here, because this is a huge need.
Yes.
But also you talk about some public health name, just that can be connect with something else, and people sometimes they against what we are trying to bring, another piece. And I always talk to my other guests about misinformation, disinformation. And in your field, what kind of misinformation, disinformation you see, and also what we need to do for that part?
I kind of alluded to this, but it's worth repeating. And that's when you get a person, and I'll use knee pain or back pain, and they think they just have to suck it up. And if they don't do it,
Yes.
or if they don't comply, it's their fault. And that's a misconception, because when they go home, we don't know what's going on at their home. We don't know their diet. We don't know how their house is. We don't know other comorbidities, meaning smoking or diabetes. We don't know how they're caring for all that. We don't know the mental health. All that plays a huge role on musculoskeletal, like the back or the knee. Mm-hmm. So it's a misconception if you don't recognize all those types of things, and on a bigger scale try to help with those things. So I think that's the biggest misconception.
But I guess there is a two messaging issue we are talking about. One is the patient's perspective, but one is also clinical and the provider perspective, because sometimes providers, they're so busy with the patients and many other things, and they don't question that kind of piece and just say that, okay, you have a knee pain, that's it, What do you feel about that part? Why maybe go back to our program side and just what kind of future physical therapists we want to see?
We want to see ones that engage with, here's the physical therapist, and we have spokes going out to all different School of Public Health programs. So for example, someone with, I'll use low back pain again, but they say, I smoke. Or they say, I'm really having a hard time at home mentally or whatever. We need to engage those folks in those spokes in the community so they can start to heal there as a whole person. And if they don't do that, I don't care what I do to your knee or what I do to your back, it's really not going to get better. And I've experienced that as a more experienced clinician. You have to recognize that. So as a clinician back in Michigan, for example, I got with the big smoking cessation people, and I said, we're going to work as a team. This is a team, because you're not going to heal it all. And I'll explain all the reasons. And they said, well, it's a team. That's good.
Because I guess we really need to see, again, patient as a whole. It's not just I am just specialties is just a knee, is not solving the problem. Exactly. So I guess is one of the main goal for us for our future program, how we can just have more physical therapists with this mindset and understanding.
Correct. And we have such amazing School of Public Health with different programming surrounding us right now. So we can work together as a school right now with all of our different programs. Yeah.
But just tell me about your research a little bit, just how also what you do with your research.
My research started, I'm certified both in orthopedics and wound management. In the wound management, I saw, it was really sad because a lot of these people who have diabetic foot ulcers, about 20% end up in amputations. And that's very sad because you can medically stabilize someone, but their quality of life changes significantly. And I kept asking the reason why. And the reason why was as simple as transportation. I can't afford coming here all the time.
Access
And
again.
it went on and on. So that was my idea to start about digital health. Is there any way I can monitor and treat people at home as kind of a hybrid? And so that started about a decade ago. And I worked at different places and developed some technology where now a person who has diabetes can put their foot on a insole and we can monitor the blood perfusion down there. And then they can be treated once a day with this electrical stimulation that seems to increase blood flow to that area. And we can monitor, which is really important, if they're doing this treatment or if they have this offloading boot. Because if they don't, then we can say, is there anything wrong? And they might say yes. Or, so that's a way to connect right away.
That is very important. And again, just sometimes our audience, we are trying to actually, right now, what I'm seeing that science is getting more marginalized and just saying that, okay, you are just doing for your interests, but it's not, just in the end, what you are trying to create is more how we can give many people more healthcare access, or, how we can help the people, because all these research in the end helping the decision making what we need to do is the next. Am I right?
No, you're exactly right. That's exactly right. Yeah. I think the more we think that way, the more we'll help the population.
Yeah, that is the part. And do you want to say anything to our listeners who may struggling with the pain or, just some issues, but they don't know what to do right now? And do you want to give some message to them?
Yeah, pain is a wonderful thing. And this can sound weird, but it's letting you know something's going on. And I always tell a story to my students that there are certain people with no pain, but yet they get burnt, they break things, and they die at an early age. So pain, but chronic pain is not. So I'm just talking here about acute pain. And also remember, pain can originate from different areas, but show up at a different part of the body. So the best thing I think to do is initially see where that pain is coming from, try to understand that, and then try to manage it the best you can. So for example, I work with a lot of people with knee osteoarthritis. We use the word manage. So if they know how to manage that knee pain, they can live a great life. But if they think they're going to get rid of 100%, some do, but some don't. So it's
because
managing.
Quality of life is very important.
Right.
Just our goal is really how we can increase your quality of
life.
Right. Is the part. As we getting the end of our discussions, I want to ask one more question. What gives you hope for public health for future?
I think making connections like we are right now, having different people from in a clinic talk about public health.
Very interdisciplinary. And
yes.
Because solution is interdisciplinary. It's not just one discipline.
That is public health in a nutshell to me. It reaches out. I think sometimes in hospitals and clinics, we all live in silos. Even in universities, we live in silos. So what gives me hope is being with the School of Public Health and also writing things like clinical practice guidelines or other guidelines that include all the things all the things we just talked about that will be disseminated then to everyone.
Thank you so much. Hopefully you enjoy again.
I did.
Coffee, but just only
one cup. One cup.
Not the two. But thank you so much
for
coming and just talking with me. It was very interesting.
It was fun. Thank you.
Thank you. Thank you.